Thank you to the organizers, particularly Morale, and of course Dr. David and the committee for inviting me to speak here. These are my disclosures. I also have to disclose that I'm a Canadian working in the United States, so every time I cross the border, I also get nervous that I'll be detained or jailed, but so far I haven't. All right, so I've been asked to talk briefly about our experience with aortic root surgery, redo aortic root surgery in particular. So what are the indications for reoperative aortic root surgery? They're similar to standard indications. The patient who had a Ross procedure by Dr. Yacoub in 2001 developed a root aneurysm in some AI, so obviously aneurysmal disease. Patients with previous prosthetic valves or native valve dysfunction, patient who had 2 prior mechanical valve replacements with a patch, both times patches dehisced and the mechanical valve is severely dysfunctional. Pseudoaneurysms, this is an example of a large pseudoaneurysm. The patient had a prior type A dissection repair. This is not a recurrent type A dissection. This is a graft that is dehisced off the proximal suture line. And so obviously this is a solid indication for surgery. The question often is, what do we do with small pseudoaneurysms? So the same patient, 2 scans apart, this patient has a small pseudoaneurysm. You see, despite the felt, so I think felt makes reoperations a lot harder, but it doesn't necessarily prevent pseudoaneurysm. Sometimes, especially if patients have had surgery within the last year or two, we'll elect to follow small pseudoaneurysms rather than put them through the trauma of another operation. But this patient has a scan not long after, but within a year, and you can see that the pseudoaneurysms have, actually there's now a new pseudoaneurysm and an enlarging pseudoaneurysm, so we elected to offer redo surgery. Obviously, patients with prior prosthetic valves, Bentals, this is a patient, my own patient that I operated on soon after I came to NYU, did well, but a year later developed a fungal endocarditis of his Bental graft. So, the one thing I would say about this is a lot of these patients don't have significant prosthetic valve dysfunction, and we try to manage them with antifungals or antibiotics, but that's really just putting our head in the sand. Eventually these patients come to surgery, and I think the sooner we reoperate on them, the better. I think planning is the key to any successful cardiac operation, in particular complex redos. We have a saying that CT don't lie. Here's a case of a patient who had a prior robotic mitral valve repair, and you can see on the CT he does have an aortic aneurysm, but most importantly, there's a large filling defect out the back of the heart. And so we usually do structural heart CTs. These are gated CTs with contrast. They provide excellent pictures. Important to look at, all the different views. Can we go back to those slides, please? And so what the CT eventually showed is that there were multiple pseudoaneurysms, one from underneath the non-coronary going out the back of the heart, and then several pseudoaneurysms under the left. I think if we tested this earlier, the computer on my left, your right, was the one where it worked best. One of the points that I was going to make later in the talk is that details matter, and I would say that I owe this from having worked with Dr. David. I'll get back to that story in a second. So here's the coronal views. It's important to look at all views. You can see as we scroll under the left main here, there's a hole actually in the left sinus of Valsalva and another pseudoaneurysm underneath the left sinus, or the left cusp insertion. The patient also had a 53 millimeter ascending aorta and a bicuspid valve with moderate AI. So we also, it's important to have good echocardiography both before and after the operation. This is just showing flow inside of one of the pseudoaneurysms under the left. So what we did is we patched the hole. We didn't open up the pseudoaneurysm cavity from the back of the heart. There was no need to, so we put a small patch underneath the non-coronary cusp, which closed the defect underneath the non-coronary cusp. And then we repaired unfortunately the video doesn't show it, but we repaired the pseudoaneurysm under the left, as well as the hole above the left cusp insertion, repaired the bicuspid valve, did a reimplantation procedure, and an ascending hemiarch. This is the echo following the repair. So it's obviously important in these complex operations to protect the heart and brain. We do, ever since we started using Del Nido, it really has changed my life. We do the induction dose as described by Dr. Del Nido, and then we redose religiously every 60 minutes. Some of these operations are quite long with 3, sometimes even 4-hour bypass runs, and if we give Del Nido every 60 minutes, we have not had a problem with myocardial protection. We extubate 90% of our complex aortic patients, even redos in the operating room, and we try to get them up walking within 3 to 4 hours after surgery. And as I said, the details do matter. Here's another case of a patient who was young, obese, on dialysis, had multiple bouts of endocarditis with 2 prior mechanical valve replacements and 2 prior patch reconstructions of the LVOT. Both failed. And in between the 2 AVRs, he had a kidney transplant, and then they were actually going to transplant him, but he had normal left ventricular systolic function, and so he was sent to us. And here we see probably the coronal show at best, but he has a tilted valve which was actually rocking, and the patch underneath the left main was dehisced with another pseudoaneurysm. I show this case just to highlight some of the tricks that are sometimes necessary. So we hadn't started cutting the mechanical valve out. The mechanical valve is half of the circumference. It's already dehisced. So everything's removed. He also had multiple prior infections. So we removed all the prosthetic material. His aortic root was reconstructed with a homograft. And occasionally the left main button is frozen and it's not easily mobilizable. And so one of the tricks we use in some cases is to use a small Dacron graft. This is not a formal Cabral procedure. This is simply a modified Cabral. We use a 6 or 8 millimeter graft and sew it to the left main and then attach it to the root graft, and it's usually just a few rings so it doesn't kink. This is a type of patient where we would extubate in the operating room, get them walking, and they often, if we can get them moving early, they can go home within 3 to 4 days. I'll just show this one last case. This was a case where a patient had a prior aortic homograft some 15, 20 years prior, and he was quite young when he had it, and then somebody thought it was a good idea to put 3 TAVI valves inside of this. He developed aortic stenosis and had a sapien valve put in, and then a core valve. That quickly failed, and then another core valve, and actually his mean gradient at this point was 88, and they were going to do it again. They were going to put another TAVI valve in. So at 38, who reasonably good ventricular function, still driving a delivery truck, we decided to offer him redo surgery. And you look at the CT on the right and you think this is going to be a difficult operation, but to be honest with you, it's really not. And it's not because the calcium helps you with the dissection. You just need to cut above the calcium. Yes, there's not a lot of room to clamp, so we ended up doing a brief period of circulatory rest. But it's good tissue above, and if you notice, and this is true of a lot of freestyle valves that degenerate or homografts, the buttons are spared. And so long as the buttons are not calcified, it's actually pretty easy. And then the other key is getting to the LVOT. Once you get below all this crap, you have something to sew to, and then it becomes a pretty straightforward operation. But here's the video. Obviously, this is like concrete. But when we do the dissection, we just stay on the calcium. It can be inflamed, and sometimes the planes aren't great, but as long as you stay on the calcium, there's the TAVI valves inside. And really the keys are just, once we take the TAVI valves out and do our initial dissection, the key is really to get those coronary buttons off so you don't damage the coronaries. And then just take your time. It takes 20, 30 minutes, 15, 20, 30 minutes, however long it takes. You do this carefully. You try to avoid injuring the PA posteriorly. We'll crack the calcium and start defining the left and the right buttons. And then once the buttons are out of the way, you're pretty much home free. The video is not much longer. So now we're getting down towards the left main, and we can start to separate that. We've done redos where the previous surgeon has used Teflon reinforcement around the coronary. That can create a lot of adhesions between the pulmonary artery, and so occasionally we'll use a 15 blade rather than the cautery to separate it without doing a thermal damage to the coronary or the pulmonary artery. I'm sorry, I can't move this along manually, so I'm just going to have to let it play, but we're almost there. So here's the key. So once you get below the calcium, then you basically just have a ring to sew to, and you can do a Ross. In this case, he was on chronic antifungal suppressive therapy and was also getting intermittent Klebsiella, so I decided to use a homograft rather than do a Ross. But you can do a Ross, you can do homograft, you can do a redo Bentol. Basically once you've defined that LVOT ring, Bob's your uncle. Just two quick cases here. This is a 24-year-old female who had a prior aortic valve replacement for a bicuspid valve. The surgeon at the time, she was 17 when she had the bio-AVR, said that they couldn't do a Ross because of pulmonary annular and aortic annular mismatch, which I don't think is a huge thing, but nonetheless, she got a Magna valve and then had an aortic aneurysm. So when you're starting out doing the Ross, I was avoiding doing the Ross in redos, but it's a pretty straightforward redo. There's not a lot of adhesions or fibrosis around the aorta. And once the valve's taken out, again, Bob's your uncle. So we ended up doing, her ascending was dilated, so we ended up doing a Ross and an ascending replacement. And lastly, this sort of is a case similar to what Dr. David mentioned. I guess I'm being cut off, but it was a patient who had Marfan's and a previous mitral valve repair. No sternotomy, was done through a thoracotomy. The point was that I'd rather often do a sternotomy redo than a redo after thoracotomy because the adhesions on the right atrium are worse. Yeah. And so here she had actually been followed. She had a chronic type A dissection and a root in ascending aneurysm. But once the adhesions are dealt with, you get back to your standard operation, and we ended up deciding to move forward with the valve sparing operation. We do use the Schaefer caliper, although I do believe in the visual assessment as well. But once the coronaries are mobilized and the roots mobilized as per a first-time operation, then again you can do what you like to do. If the valve's repairable, we went ahead and repaired the valve. So in conclusion, I would say that reoperative root surgery poses additional challenges to first-time surgery, but following certain principles, it can be done safely with predictable results. The key to success, like all heart surgery, is planning, 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 and details matter. Thank you very much.